Hi, so this is my first video that I'm using for teaching, and I'm basically going to give the same presentation I gave today to my medicine group. And it is about prolonged QT syndrome, which can be abbreviated to long QT syndrome. Right? And if you, right, when we look at this waveform, here's the P wave, Q, R, S, and the T. QT interval is going to go from the beginning of the Q to the end of the T. It's this long. It's about two big boxes. Each big box is 200 milliseconds. So times 2, a normal QT would kind of be around 400. But here's the catch. If you think about fast heartbeat or slow heartbeat, in a fast heartbeat, QT interval is going to decrease. A slow heartbeat, in which there's a long distance between the R and the R, you can imagine the QT is going to be even longer. So we can't give QT a number. We have to calculate something called the corrected QT. The corrected QTC, you can use any med calculator. Usually people use apps on their phones. But if you wanted to be academic about it, there's multiple equations you can use, and there's controversy over when to use what. But if someone's heartbeat is between 60 to 100, which is a pretty normal range, we can use something called, I forget whose name it was, but we use the equation QT length over the root of the RR distance. If someone's heart rate is either bradycardic below 60 or tachycardic above 100, we use a different equation called RR to the 1/3. Either one of these is acceptable, and either one of these can be used. So why does this matter? Well, it matters that if this QT interval gets prolonged, right? Prolonged QT can lead to a ventricular arrhythmia. And one such ventricular arrhythmia is torsade de pointe. If you think of ventricular tachycardias, they kind of look like this. Torsades looks like this twisting around a wave or something like that. And ventricular arrhythmia means that the ventricles are no longer pumping, and the heart and the heart can really only do that for a few minutes. So if you sustain this ventricular arrhythmia and then the heart just doesn't beat, you're basically going to end up dead. And usually that's a sudden death. We want to avoid this from even happening, okay? And so we have to be aware of people who... Now, in prolonged QT syndrome, there's so on QT syndrome, there's two categories. There's either genetic or there's acquired. And the genetic, we know, like the Romano-Ward syndrome or the Dravet-Lang-Nielsen. This is autosomal dominant, and this is autosomal recessive. Remember that this has only a cardiac phenotype. This is both a cardiac and a sensory neural hearing loss phenotype. And remember, Romano-Ward is the most common. I believe the incidence is actually kind of huge, 1 in 2,500 to 9,000. But, you know, it does exist. So then there's a bunch of acquired causes. And there are many other classified, and they're classified by their gene type, and the gene type name is like LQT1, and then 2, and then 3, or whatever. So there's a lot. The acquired can come, and I've tried to think that acquired comes from 3 things. There's cardiac reasons, there's electrolyte reasons, and then there's cardiac, electrolyte, and drugs. Okay, so the cardiac reasons could be an MI, rheumatic fever, cardiomyopathy, third-degree heart block can do that. Electrolytes are the hypocalcemia, kalemia, and magnesemia. And just to refresh your memory, the most common reason why people go into torsades is because of hypomagnesemia, which is why the treatment for it is to give magnesium, and you give magnesium immediately. And if you give magnesium, it should correct pretty quick, and you oftentimes don't need to give the lidocaine or the amiodarone that you would typically give in a ventricular tachyarrhythmia. That is, I guess, relatively stable. And what everybody gets tested on are the drugs. So what everyone gets tested on are the drugs. So I'm going to kind of create this separate space in order to talk about it. A lot of people have, there's like so many different types of mnemonics that people have in order to try and remember this, but sometimes it's just easier to remember the classifications. So there are class 1 antiarrhythmics, which are disopyramide, quinidine, and procainamide. There's class 3 antiarrhythmics like amiodarone, dofetilide, ibutylide, and a lot of the other ones. Quinidine you get asked, amiodarone you get asked. Antipsychotic meds. And you can have typical and the atypicals. Of the typicals, I believe it's chlorpromazine, but I could be wrong. Yeah, I'm probably wrong, but whatever. And then the atypicals are quetiapine, I think risperidone, another one. This is Seroquel, and people will often shut off the Seroquel so you don't have to deal with it. Then there's an antibiotic class, there's an antibiotic, there's malarial, and then there's the viral. Now the antibiotic class are the macrolides. Erythromycin gets asked a lot. The antimalarial is chloroquine, and then the antiviral are protease inhibitors. And those are the navirs. So these are the meds. Then there's the diuretic class. Of the diuretics, there's botched that. There's hydrochlorothiazide. Remember, this is a very common diuretic that's prescribed. Very common. And a lot of patients, you pay attention, right? Thiazide diuretics. The patient will come in, maybe sudden cardiac arrest or whatever, and then you look back in their records after they're stabilized and you say, they were hypertensive and they were taking a thiazide diuretic. Maybe that contributed to it. There was a final class. I left my papers in the room. There was a final class which was right, and then the antidepressants. Of the antidepressants, they're TCAs. So I want you to pay attention to one key fact that will help you remember this. So we know that there's an antimuscarinic. And antimuscarinic basically means atropine-like. And TCAs have antimuscarinic effects. Class 1 have antimuscarinic effects. The antipsychotics have antimuscarinic effects. So for these classes, this is the reason why they prolong QT. Okay, it's the antimuscarinic effect that's in them. I'm not exactly sure why. We're going to have to go over that later. So a good way, so a lot of people come up with mnemonics and ways to remember it, but that really just didn't help in this scenario for me. So I think the most useful thing, for me at least, was to kind of have these 6 classes. I mean, these got broken up, but these are the diuretic and the antidepressant. And just remembering these 6 things and kind of repeating it a lot of times and really being vigilant about it helped the most. How do we work up a QT prolongation? There are multiple things that you have to do. Let me just try to think. There are multiple things that you have to do, right? First, you got to think about their clinical presentation. Usually these people come in with syncope, palpitations, seizures, and so you're really looking to assess what exactly happened, because a lot of times these people will have congenital prolonged QT, and one of these other factors, taking this medication, hypokalemia, hypomagnesemia particularly, will kind of tip them over the edge into ventricular arrhythmia. So we really don't want to be calling these patients seizure patients when really they're cardiac patients. Family history. You know, this is going to be hard to kind of figure out, especially because of the genetic component. We can't genetically test everyone, ideally we would, but you can ask sudden cardiac death in the family. You calculate the corrected QTc, okay, using any one of the formulas. You can calculate, there's like a Schwartz score, and a Schwartz score kind of tells you basically their risk for having this, and it you know, there's so many components to it. There's a clinical component. So what was the condition with it? They syncopize, is it because of stress or not because of stress? Then there's like a family history component. Anybody have a history of sudden cardiac death? And then there's like the EKG changes that you have to pay attention to, like are there T-wave inversions, et cetera, et cetera. So there's a score that you can calculate. I don't know if you're going to be doing that on the floor, probably the cardiologist. And then finally, there's exercise testing. And typically, if you ask someone to get on a treadmill and you speed it up, they're going to become tachycardic, and their QT interval is going to, they're going to be tachycardic, and their QT interval is going to shorten. But in some people, something paradoxical happens, and you speed them up on the EKG, and it actually lengthens. And this is one particular phenotype of prolonged QT, but you want to do this test to know whether or not that's present. So this is really how you work up the patient. And I guess the most important thing that I kind of should have said at the very beginning, the most important thing is that, why are we doing this whole workup? You know, why do we need to know all of this? Because you basically want to treat them in 2 ways. Number one, you're either going to give them a cardiac pacemaker, right? Say, for example, they have this 3rd-degree heart block, right? You're going to want to make sure that these people are paced. Or number 2, you're going to want to put in an implantable defibrillator. Again, if you go into this ventricular arrhythmia, you're going to need to defibrillate them. And this is pretty much why we do the whole workup, because we want this patient to end up with one of these. Okay, so that's as much as I know about about prolonged QT syndrome. My 15-minute limit is about to end, but this is kind of perfect timing. Okay, thank you. Bye.